Good morning to one and all present here. Today I am going to present an interesting case of geographical keratitis. To introduce, herpes simplex keratitis is a common potentially blinding condition in which the virus remains latent in the dorsal root ganglion and can reactivate in conditions like immunosuppression. The initiation of oral and topical antivirals are the mainstay of treatment. A 66-year-old male presented to our OPD with the chief complaints of sudden, painful, profound diminution of vision in the right eye, along with redness and photophobia since 8 days. There was no history of any ocular trauma, and systemically, the patient also had complaints of high grade fever since 2 months, after which the patient was diagnosed with tubercular meningitis and was admitted under neurology in our hospital and was receiving injection dexamethasone, mannitol, and injectable along with oral anti-tubercular treatment since 6 days. On ocular examination, the visual acuity in the right eye was counting fingers 3 meters, which was not improving, and the near vision and refraction could not be assessed, and digitally the intraocular pressure was within normal limit. The eyebrows, eyelids, lacrimal apparatus were within normal limit. Lacrimal syringing was patent in both eyes, and conjunctiva in the right eye showed circumciliary congestion with palpebral conjunctival congestion. On corneal examination, the sensations were found to be reduced in all the segments, and a geographical shaped 7 into 4 mm sized paracentral epithelial defect was noted with scalloped margins, which was staining positive with fluorescein. The anterior chamber, iris, and pupil were within normal limit, and the lens showed nuclear sclerosis and cortical cataract in both eyes. The differential diagnosis of these were ruled out on the basis of the signs mentioned here, and provisional diagnosis of right eye paracentral geographical epithelial corneal ulcer secondary to a herpes simplex keratitis reactivation was made in a known case of tubercular meningitis, which was based on the history of systemic immunosuppression, reduction in corneal sensation, and geographical shape of the corneal ulcer with terminal bulbs. The management decided for this patient was to continue systemic antitubercular drugs and injection dexamethasone, and to add tablet Acivir 800 mg 5 times per day along with topical eye ointment Acivir 5 times per day with cycloplegic and lubricants. And on follow-up after 1 week of presentation, the corneal sensation significantly improved. There was complete resolution of epithelial defect with some residual superficial punctate keratitis. What is unique in my case is that the patient was started on oral antiviral despite only having epithelial keratitis because the patient was systemically immunosuppressed. In this case, tuberculosis coexisted with herpes simplex keratitis, and there was complete resolution of the large epithelial defect within a span of 1 week, despite the patient being on systemic steroids. So the clinical implication is that a diligent history and examination is important with prompt staining and ocular sensation evaluation. Tuberculosis per se can also directly affect the eye with conditions like pectinulosis, uveitis, etc. And in such cases, early initiation of topical as well as systemic antivirals is important. Literature review of similar cases are these, and the take-home message in my case is that a geographical keratitis case must be properly evaluated, and initiation of oral antiviral should be started even in epithelial keratitis if the patient is immunosuppressed. Long-term continuation of oral antivirals are important, and proper clinical photographs must be taken for the analysis. And as the disease is highly recurrent, regular follow-ups is important for complete treatment of the patient. Thank you.
Thank you. Is there a mistake? I think you have written long-term oral steroid is required.
No, sir, that was antivirals. That is.
I think that's a typo. Yes. Please correct that. So, steroids should be avoided in epithelial keratitis. That would lead to geographic. This is a very important point. If patient is immunosuppressed, which is there in most cases of herpes, and we often don't rule it out. In those cases, you have to give oral acyclovir for even for epithelial keratitis. Any comments, sir?
No, fine. No, so to prevent recurrence, oral acyclovir, but how long would you like to?
So for epithelial, chalo, you first answer, then I'll answer.
Sir, for as long as required could be 6 months to 1 year also.
So it has to be at least for 6 months, but best is please you have to give it for 1 year. And what is the amount of reduction in recurrence that you will get out of that? 40 to 50%. So don't tell the patient that since you are taking oral acyclovir, it won't recur. The patient will be after your life. You have to convey them, even if you are taking this, there is still a 50% chance that you may still get a recurrence. Okay? Thank you.